Okay, hello. Again, thank you, Manos and Manos, for the kind invitation to talk about the current evidence on SCR using the Fascia Lata. Okay. So, the history behind this is the pioneer in arthroscopic SCR was Professor Teresa Mihata, using Fascia Lata autograft harvested openly from the thigh to perform a superior capsular reconstruction. Then the Americans came in and replaced the Fascia Lata allograft with a human dermal allograft to avoid donor site morbidity. And in Portugal, we tried to avoid donor site morbidity by performing a minimally invasively harvested Fascia Lata autograft harvest to perform the same procedure as Professor Mihata described. And then came other colleagues, such as Joan Barth and Achilles, who tried to perform the SCR using the biceps autograft, and other colleagues using the hamstrings. But if we look at the history of the evidence, and most of you know these systematic reviews, for instance, this one from 2019, when comparing 10 different treatment modalities to address patients with preserved glenohumeral cartilage with irreparable posterior superior rotator cuff tears, they found that the modality that performed best in terms of providing the highest constant score improvement was using the SCR. And if you look at the threshold of the minimal clinical important difference, you'll see that the latissimus dorsi papers were below this threshold of improvement, and also the long head of the biceps tenotomy from France. If you look at another systematic review looking at different treatment modalities for massive irreparable rotator cuff tears coming from the American Shoulder and Elbow Surgeons' massive cuff evaluation and research initiative, you'll see again that the SCR using the Fascia Lata performed best in terms of providing the highest improvement in the AZ score, well above the minimal clinical important difference. And in this paper, they presented the results regarding SCR, but they then separated the results and they looked into the human dermal allograft separated from the Fascia Lata, and you see that the Fascia Lata superior capsular reconstruction almost fared twice best than using the SCR with human dermal allograft. And again, the latissimus dorsi transfer below this threshold of the minimum clinical important difference for the AZ score. But you know this paper, in America, a survey was sent to 260 Arthroscope Association of North America Association, and the 260 surgeons who replied, 51% had decreased their volume in doing SCR in the past 5 years. But if you read carefully, 76% of these surgeons were using the human dermal allograft. 12% were using the biceps to do the SCR, only 11% were using Fascia Lata, and 1% were using other grafts. So when we talk about SCR, we have to be careful at the data, when you look at the data. This is a very nice study that was published in Arthroscopy Journal by Hamad from the group of Patrick Denard. They looked at the results of the SCR using the human dermal allograft at a minimum follow-up of 2 years in 350 patients, and none of them had a control MRI. And they showed that the patients improved from preoperative to postoperative to 79.6 in the AC score. But if you put the graph that I used in the other systematic reviews and you place here the SCR with human dermal allograft from this study, you see that it doesn't even reach the minimal clinical important difference for the AZ score. If you put here the results from the SCR Fascia Lata study from the American shoulder surgeons study from 2020, they fared much better. And even if you look at the 2022 study from Hasegawa, you see again much better results in terms of AZ's improvement. What about comparing SCR versus latissimus dorsi transfer? In this paper with minimal clinical outcomes at 5 years, the group of Peter J. Millett showed that the SCR with human dermal allograft performed better than the latissimus dorsi transfer at 5 years follow-up. If you place the graph again, looking at the AZ's improvement, you see again the same. Fascia Lata fares much better if you look at all the studies using Fascia Lata. And what if you compare with the new kid on the block, which is the lower trap, This study is coming from the Mayo Clinic using Bassem El-Hassan's technique, who is a big friend of mine, and they showed that comparing the AZ score postoperatively, the superior capsular reconstruction using the human dermal allograft was better, even though without statistical significance, than the latissimus dorsi, at a minimum follow-up of 1 year. But if you look at the data carefully, you see SCR was significantly better in terms of VAS, in terms of forward flexion, in terms of forward flexion strength, in terms of internal rotation strength compared to the latissimus dorsi. And if you look at the argument, which is external rotation, you'll see that the patients who underwent SCR with human dermal allograft improved in terms of external rotation significantly, and compared with the lower trap, this difference was not significant. But in terms of strength, using the SCR with human dermal allograft improved external rotation strength significantly better than the lower trap in the Mayo Clinic. And so, if you try to compare in terms of improvement of the AZ score, looking at the same graph that I had placed before, you cannot compare because they don't have the pre-op assessment of the AZ score. But if you compare only in terms of post-operative AZ score, again, who wins the fight? SCR with the Fascia Lata at 5 years follow-up, SCR with Fascia Lata at a minimum follow-up of 2 years, and we're comparing with SCR with the human dermal allograft at 1 year minimum follow-up and lower trap at 1 year minimum follow-up. So this is why we continue to do SCR with the Fascia Lata, because our results are that at 3 years follow-up, patients improve significantly and well above the minimal clinical important difference in the constant score. They continue to improve from 2 to 3 years because their native glenohumeral joint center is restored after the ASCR, so they restore their 2-to-1 physiological scapulohumeral rhythm. And the donor side morbidity is not significant. You have a 0.57 VAS in the harvested thighs in 39 patients at a minimum follow-up of 2 years, so 95% of satisfaction with this procedure. This is a frightening table that I have here, looking at data until 2022, and this is to show the MRI controls of the SCRs. This is to show you that in the study by Joan Barthes, you have an 8.3 read tear using the biceps, but it's only ultrasound controlled at 1 year follow-up. But if you look at the evidence of Fascia Lata, you'll see that in 10 out of 11 studies, so 91% of the studies, have controlled all the patients, each and every patient with MRI, and the range of read tear is 4% to 41% when you're using a transosseous equivalent fixation at the lateral row. When you compare this with the studies of human dermal allograft, you have 36% only of these studies controlling with MRI the patients, and the control goes with a follow-up much smaller, with much higher tear rate much earlier. You even have patients tearing 50% of the grafts at 0.3 months with human dermal allograft. And if you look carefully at type of fixation, transosseous equivalent versus single row is also significant if comparing human dermal allograft or Fascia Lata fixation. So regarding the most current evidence from our group, we have just published in Journal of Visacos a computer modulation or a computational analysis of the influence of the rotator cuff tear pattern in shoulder stability after arthroscopic superior capsular reconstruction. So we modeled rotator cuff tears only with an irreparable supraspinatus tendon tear, or irreparable supraspinatus and subscapularis, or irreparable supraspinatus and infraspinatus, to see if this influenced the result. And what we found is modeling with biomechanical data from our type of Fascia Lata SCR, that there was a difference indeed, and that SCR with Fascia Lata significantly improves the glenohumeral joint stability in irreparable rotator cuff tears when only the supraspinatus tendon is irreparable, because when the other tendons are irreparable, you should address them, at least they should be partially reparable, or you should address them with tendon transfers to obtain the same result. So in conclusion, this technique has a value for patients with preserved glenohumeral articular cartilage to restore the vertical and the horizontal force couples without damaging the scapular force couple. So it's indicated for irreparable supraspinatus tendon tears. you should repair the subscapularis if it's torn to restore the horizontal floor scupples. The infraspinatus should be at least partially reparable as per our computational analysis. You have good results at the longer term follow-up if you use the Fascia Lata autograft. You should fix the graft to the greater tuberosity using transosseous equivalent type of fixation. You have better results if you have graft integrity, lower tearing rates with Fascia Lata, and the donor site morbidity using our technique is not significant. So thank you very much for paying attention.